We're here at the IS doing a follow-up on the hepatitis work that was presented at the conference. We're here with Mark Sulkowski from Johns Hopkins University in Baltimore, and we appreciate you taking the time away from your busy schedule to do this. And I'm going to allow you to present, first of all, what you did. You did a liver section presentation yesterday.
Sure.
And allow you to talk about that first.
Yeah. Well, thanks, Fred. Happy to be here. So at the session at this year's meeting, there was a hour and a half plenary dedicated to liver disease in people with HIV. And this covered a couple of different topics. The first was using means other than liver biopsy to determine how much liver damage a person has from hepatitis C. And there were a couple of presentations using blood markers, but not expensive ones that we typically get routinely. Things like ALT and AST levels, the so-called liver enzymes, as well as the platelet count. And there are a couple of formulas that doctors can use to calculate liver damage. And one study, particularly from Italy, the cohorts for people with hepatitis C and HIV co-infection, the FIB4 and APRIs are called. These are formulas that include the ALT, AST, and platelet count, did predict whether someone would get into trouble with liver disease over a period of several years. So that's helpful because liver biopsy is something we certainly would like to get away from. Now, the second part of this session was dedicated to new advances in hepatitis C therapy. And this has been a very rapidly moving area, and certainly hepatitis C has been a major problem in patients with HIV. What we've seen is in many regions where effective HIV medicine, antiretroviral therapy, is readily available and people are taking their medicines, well, HIV deaths have dropped dramatically, and that's great news. But at the same time, as folks have been living longer, we've seen liver disease due to chronic hepatitis C, which is slowly progressive, begin to manifest as cirrhosis, liver failure, liver cancer, and to this date, liver transplant is still very difficult to obtain in people co-infected with HIV. Perhaps not so much because it's not permissible, because many centers, including our own at Johns Hopkins, will perform transplants in people with HIV. It's just that the organ availability is quite tight for all patients with liver failure. So that leads us to treatment. If we can cure the hepatitis C, we can prevent these things from happening. So we had two data presentations. The first I gave on part one of the so-called Turquoise 1 study. This included 3 new hepatitis C drugs taken together along with one of our old drugs, ribavirin. Now, people with well-controlled HIV on either atazanavir, Rayataz, or raltegravir, Icentris, were permitted to take these 3 drugs plus ribavirin for 12 or 24 weeks. And the overall sustained response rates were above 93%. Now, we think this means these patients are cured. We're going to follow them longer. But the other piece of really good news is that these success rates were identical in this study of people co-infected with HIV as they were in people with hepatitis C alone. So really good news. Perhaps even better news, the therapy was well tolerated. No individual had to stop treatment because of side effects, and there were really no serious side effects reported. So overall, very good news. The second study was the Photon 2 study, which essentially confirmed what we know about the drug sofosbuvir, which is available in many parts of the world, known by the trade name Sovaldi, plus ribavirin. Now, this study was done in Europe and Australia, treated patients with genotype 1, 3, and 4 for 24 weeks. Those with genotype 2 got 12 weeks, and they showed very nice response rates. This all-oral interferon-free treatment led to a hepatitis C cure in more than 85% of people treated. And that's another great option. So what we're seeing is that these advances in hepatitis C treatment are moving into the area of co-infection and the results thus far have been really spectacular.
Are there any options that are more specific for different patients, for one patient over another?
I think the biggest thing we're going to have to deal with, so many of us now think that people with HIV, treating their hepatitis C is really no more complicated from a standpoint of the virus than it is in someone with hepatitis C alone. The real issue is the drug interactions. So when I sit down with someone who is on antiretroviral therapy and I'm looking to pick a regimen to treat their hepatitis C, what I'm really going to look at is how can I choose a regimen that's safe and effective but also compatible with their HIV regimen. Now we could make changes, but I can tell you many patients and most doctors are of the school, if it ain't broke, don't fix it. So we prefer not to take someone off a regimen of HIV that's working so well, because that's a long-term therapy. We need that for 10, 20 years. Hepatitis C treatment's 12 weeks. So what I'm looking for is a safe, effective treatment that fits that patient. So it's really the drug interactions that are the defining feature.
So are there any other pieces that the conference has presented here that you feel that might be worthy of our audience?
Well, I think the main issues are a growing attention to both hepatitis B and C. Viral hepatitis, when one looks globally, is a major cause of death. It's one of the leading infectious cause of death, ranks right up there with HIV, TB, and malaria. But we rarely talk about it in that context.
It's very slow progression, so it's kind of the frog in the boiling pot.
Yeah, and when you look at the United States, where I practice, well, more people die of hepatitis C than HIV. Now, that's not to say that HIV is not an important fact, because there's still 7,000 or more people dying every year. But it also reflects what we can do with good medications, a good education, and efforts to screen and diagnose people. So my hope is that some of this momentum that we're seeing with new hepatitis C treatments will lead to a commitment to screen, diagnose, and link to care people with hepatitis C. And we've really not done a good job with that in the United States, let alone the rest of the world.
It seems like because of people are being diagnosed with HIV, then they are tested for hepatitis C, whereas people who are maybe just living with mono-infection are not as easily suspect.
Well, I think that's absolutely right. We, in our clinic at Johns Hopkins, known as the Moore Clinic, we pretty much know who's hepatitis C infected, because part of the entry into care panel is hepatitis C test. And if people are negative, we're repeating the test on an annual basis. So we're picking people up. We know if they're infected. So for us, the challenge has been connecting them to treatment, because the tools we've had before this era have been just very difficult to use. Whereas in other settings where people are not in medical care, we've got to find those folks. So in many ways, all the work that's been done for screening, diagnosis, linkage to care, and HIV makes the work for hepatitis C a lot easier.
Are you doing this with the general population or just with those who are infected with HIV?
So we're working in both populations.
Okay. So it's an opt-out test, is that it? Or do you...
It's really, so
it's a package.
It's a package test. In the when people enter our HIV clinic, it's a package part of the test. We'll do a CD4, an HIV RNA, a test for syphilis and other diseases that someone might have picked up along with HIV. And hepatitis C is an important one. In fact, in our clinic, about 50% of people, one half, are hep C infected.
Wow. Well, I believe you probably covered the short picture. And I know we said earlier that we'd certainly like if there's any other information. There's plenty of information online about the conference itself, but I thought this was a good capsule to introduce what actually was important that happened here at the conference.
Yeah, sure. Thanks.
Thank you very much. I appreciate your help.